Good evening, everyone, and thank you for joining us at the Cleveland Clinic in our discussion on kidney transplant and living donation. My name is Christina Delvalle, and I am one of the kidney transplant social workers, and I will be the moderator for this evening's webinar. We will have a presentation given by our experts, followed by a question and answer section. There is a chat feature on your screen. It's called Q&A at the bottom right, and you can use this to answer questions, which we will answer at the end of the program. This is a live event and being recorded, but will be kept confidential. None of your personal information or identity is being shared, so please do not disclose any confidential information when you ask your questions. I want to introduce our experts who will be presenting tonight. They are 3 nephrologists from our kidney transplant team. First, we will be hearing from Dr. Augustine, originally from Michigan, trained in Chicago and Cleveland in medicine, kidney medicine, and transplant. He has been practicing kidney transplant medical care for over 20 years and is currently Associate Professor of Medicine in the Cleveland Clinic Lerner College of Medicine. He is the Transplant Nephrology Fellowship Program Director and is the overseeing nephrologist for the Kidney Living Donor Program at Cleveland Clinic. Following Dr. Augustine, we will be hearing from Dr. Hummel. Dr. Hummel is a graduate of Northeast Ohio Medical University and completed internal medicine residency and nephrology fellowship at University Hospital Cleveland Medical Center. She has received funding to study barriers to care for patients with failing kidney transplant from the National Institute of Health. In addition, her research focuses on health disparities and access to kidney transplantation. Finally, we will hear from Dr. Fatika. Dr. Fatika graduated medical school from the Medical College of Virginia and completed residency in internal medicine at University of Pittsburgh Medical Center, followed by fellowship in nephrology at the University of Michigan. He has been a clinician educator at Cleveland Clinic for 23 years. He has held many leadership positions in the past and is currently serving as the Vice Chair and Quality Officer. All right, thank you experts for being here tonight, and we are also excited to learn from you. Dr. Augustine will be reviewing the kidney donation process, options, and paired donation. Dr. Augustine, go ahead and take it away.
Thank you very much, Chrissy, and welcome to those who are listening in. Hope you can learn a little bit tonight, and please don't hesitate to ask questions. So our focus today is on living kidney donation, and obviously, as it sounds, this involves a healthy person giving a kidney to someone whose kidneys are not working well or don't work anymore. We have terminology for kidney failure, often calling it end-stage kidney disease when somebody actually progresses to the point where they need dialysis therapy or kidney transplant. But it's important to know, and some people think that you would have to go on dialysis before receiving a transplant, but that's not the case. And with live donation, in many instances, it allows us to proceed with kidney transplant prior to someone ever needing to go on dialysis. We look at estimated kidney function, and when it gets to a certain low level, patients are eligible for kidney transplantation, and that may occur before they actually reach dialysis. And it's much more likely to occur before dialysis if they have a living donor. And there are nearly 100,000 patients with kidney disease and kidney failure waiting for a new transplantation. And living donation helps to lower the shortage of people waiting for deceased donor transplantation. It's also almost always associated with shorter waiting times and also better patient outcomes. Next slide, please. So a living donor has to be healthy and they have to be motivated. It takes a very special person to consider donation, and it is a gift. It is a sacrifice to give up a kidney. Obviously, it's a very very special gift. Living donors have to be adults. They have to be 18 years or older, and they undergo extensive evaluation with physical and social evaluation, along with lots of lab tests and imaging procedures. And testing will include a lot of blood tests, urine tests, including testing for infections such as hepatitis and HIV. There are at least one 24-hour urine collection that is obtained. Sometimes that has to be repeated 2 or 3 times. For example, if a patient has a history of kidney stones, they have to undergo a special 24-hour urine collection to look for risk for future kidney stones. We obviously don't want to see a donor end up with a kidney stone later on down the road. There is a special laboratory test that is precise in terms of looking at kidney function. There are cancer screening tests depending on the donor's age. If a donor is over the age of 45 to 50, for example, they may need a colonoscopy prior to approval for donation. There are heart tests such as EKG, chest x-ray as well. And in some patients who may be at higher risk, some donor candidates may need additional cardiac testing such as stress tests. Donors always have a CT scan as well as part of their evaluation, which gives a very detailed anatomy of the kidneys and also sometimes picks up on other abnormalities. And occasionally we evaluate a donor who ends up having some medical conditions that may not allow them to become kidney donors, but they are often fortunate or grateful to receive the information that allows them to pursue the care that they need. We also we look at blood pressure, and sometimes we do a 24-hour home blood pressure monitor if the blood pressure is higher in clinic. Next slide, please. The most common type of transplant is a directed transplant where the donor proceed together and the donor donates directly, and that can be a living related or unrelated transplant, and we define that, of course, by blood relatives. Blood relatives such as parents, siblings, or offspring may serve as related donors, but it's very common to have an unrelated donor as well. And another misconception with living donation is that you have to be a very close relative or to match very closely. Really, you just need to have suitable blood type, and you have to have a cross match to ensure that there's no antibodies that the recipient may have against the donor. But it's very common to see donation, for example, from a partner or a spouse or a close friend who isn't a blood relative. And we call that, of course, living unrelated transplant. Now, in order to proceed with a direct donation, you do need to match blood type with the person that you care for, that you want to see receive the kidney. And if you're blood type O, you can donate to any other blood type, which is very convenient. And on the other hand, we rarely see it, but blood type AB allows a recipient to receive a kidney from any blood type donor. Next slide, please. There are different types of kidney donation, including directed, which is the most common. Again, you as a donor would donate directly to your loved one. But we also do what are called exchanges, and these can be paired exchanges, or they can even be a chain that can be created with multiple donors and multiple recipients. And this occurs if the donor and recipient are not a match by blood type, or if the recipient has antibodies against the donor's blood proteins. And essentially, for example, with a paired exchange, the donor would donate to a stranger, knowing that in exchange, that stranger's partner or that other couple would have the donor donate to the person that you originally intended to donate. So it creates a so-called swap or exchange. And we try to explain it to potential donors that they're essentially donating to their loved one indirectly and allowing that to occur through a paired process. Finally, every couple of months, we encounter a donor candidate who's so-called non-directed or altruistic. And these are potential donors who actually don't know any recipient, don't have anyone specific in mind, but they choose to donate somewhat anonymously directly to the list. And we, as a transplant team, try to figure out who would be the best match for that donor. They, of course, go through a very careful workup, but they're often just very rational and have made up their mind that that's something they want to do. They often have donated in other ways in their life, such as donating blood or bone marrow. And these are very special people. And these can often help to create an exchange or paired exchange or even a chain of transplants because of their non-directed or altruistic donation. So I'll stop there and
Great, thank you so much, Dr. Augustine. So next we will be hearing from Dr. Hummel, who will be educating us on the donor perspective, decision-making process, and donor advocacy.
Thank you, Josh and Chrissy. So many prospective living donor candidates may consider the risks and benefits of kidney donation as part of their decision-making process. In these two tables here, you can see that I've listed the benefits and risks of living kidney donation. On the benefits side, this came from a report published in 2020 where a team of transplant professionals interviewed prior living donors. and categorized what they perceived as the benefits of donation. Many of the donors who they spoke with and interviewed lived with their intended recipients or had a caregiver role for their recipients. So as you can see here, the major benefits perceived by the donors were health and well-being, that the donor in the decision to donate was being proactive about his or her own health. They may have experienced improved quality of their own life, and perceived benefit as waitlist priority if they were ever in need of a kidney transplant. The second benefit listed is time and financial benefits. So if you think about a donor giving to someone who they're the caregiver of, a spouse, a partner of, they may feel reduced caregiver burden after their recipient receives a kidney. They may have improved benefits of being able to travel more liberally without needing renal replacement therapy in the form of dialysis. Their intended recipient can return to work, get a financial benefit from improved careers, and have more free time. Donors also reported interpersonal benefits where they felt closer relationships to their recipient. They preserved the family unit. They joined a community of other living donors. They could watch their children grow up together and improved social life. Other benefits are listed there. They felt the ability to help others. They essentially saved the recipient's life. They had an increased sense of purpose. Some of them believed in karma, that good things would come back to them after the act of living donation. Improve relationships with the recipient's family if they weren't necessarily a family member. And then they helped the recipient avoid dialysis or discontinue dialysis after receiving the transplant. On the risk side, most studies suggest that you can live a normal and healthy life with a single kidney. However, there certainly are risks to donation. As far as risks, there may be short-term complications of the surgery. Rarely, donors experience physical changes, and those may be the scar that the surgery leaves, some pain, or even some hernias. Women who donate prior to being pregnant and conceiving children may have increased risk of gestational diabetes or hypertension. And one risk that we always really focus on is the risk of a potential donor's future kidney failure. So we've quantified this in large studies over time, and a lifetime risk of anyone in the general population here in the US of developing kidney failure in the future is about 3.26%. Of a healthy person in the US population, lifetime risk of kidney failure is about 0.14%. And then of the average kidney donor, again, this is someone who's undergone a lot of testing that Dr. Augustine talked about in the first couple of slides, is lifetime risk is estimated to be about 0.9%. So you can see the estimated risk of the average kidney donor falls somewhere between a healthy non-donor and members of the general US population. Other risks may be those of psychosocial changes, financial changes, and confidentiality. Next slide. So I'd like to talk a little bit about the donor perspectives. So each year in the US, approximately 5,000 to 6,000 living kidney donor transplants happen. After donation, there are several platforms where living donors who go through the process can kind of tell their story, and I've listed some examples of them here. I'm sure there's more than what I have only on this slide, but let me highlight these three. First, the Living Donation Storytelling Project is a digital library of video stories. Dr. Waterman, who's a researcher about kidney transplant in Texas, began collecting these stories in 2018. And it's been developed by participants recording their stories through iPad, iPhone, other tablets, their home computer. And the stories are connected together on this website that you can see listed here at the bottom of the screen. Two other programs have been developed through the National Kidney Foundation. One is called the Big Ask, Big Give, which is an online program to educate patients and potential donors about living kidney donation. And the second is the National Kidney Foundation Peer Mentoring Program. Both the website and the number are listed there at the bottom of your screen. And there are many videos that living donors have made and posted on the Big Ask, Big Give website as well. The NKF Peers Program, there's a phone number and an email address listed there, where National Kidney Foundation will connect you with a peer who was a living donor before, and then you can have a more personal interaction with somebody who may be able to help. Next slide. So recognizing over time the altruistic gifts of living kidney donation, there's been many advocacy efforts that have gained traction. I list 3 of them here, but again, there may be more. One is the Living Donor Protection Act. It was introduced nationally by 2 representatives, one from New York and one from the state of Washington. This bill or act intends to protect living donors and remove barriers to donation by limiting insurance companies to prohibit living donors from not being able to be insured. The Living Donor Protection Act also intends to protect living donor jobs. So at this point, the Living Donor Protection Act has been signed into law in many different states, but not necessarily at the national level yet. The picture that you can see down there, the group gathering, is Governor DeWine in Ohio. It was passed into law in April of 2022 in the state of Ohio under House Bill 188. So living donors in the state of Ohio do have protection against being denied insurance and job loss. The second aspect of donor advocacy that I'd like to talk about is the American Society of Transplantation Living Donor Circle of Excellence. So that's kind of the logo that you can see there in the middle. What the American Society of Transplantation has done is partner with about 130 companies to become part of the Circle of Excellence. These companies recognize living donation through approved time off in work and supportive measures to living donors. And then finally, there's many publications that talk about not the financial implications of becoming a living donor, either from lost wages, need for dependent care for potential donors who have children or loved ones they help care for, and time off work or with lost wages or even travel costs. So the National Living Donor Assistance Center has been in existence for about 15 years. And living donors can apply for compensation for these specific needs during the time of their transplantation. So I'd like to thank everyone for attending tonight, and I'll hand it off to Dr. Fatika, who will speak next.
Right. Thank you so much, Dr. Hummel. Next up, Dr. Fatika. He will be discussing the transplant experience for donors and recipients.
Thanks, Ann. Thanks, Chrissy. So maybe a little facetious, but I thought that I would give you a little bit of my impression of the experience of going through the donation process. And, there's a great sense of urgency when somebody decides to donate. And they want the testing done right away, and they want to be able to donate right away. And this, of course, to help their loved one. But from both the donor and recipient experience, it can be frustrating. And it can seem like it's a very slow process to get all this testing done. But rest assured, we have to go through this required process to ensure that we do everything with a minimum amount of harm to both the donor and the recipient, and that we help make the best decision for the best outcomes. Next slide. When the day is finally here, there's a great amount of excitement on both the donor and recipient part, and sometimes it seems like, wow, it's going to happen today. Next slide. And the donor and the recipient will typically be in separate operating rooms, and the surgical procedure will involve your surgeon very likely doing a laparoscopic procedure. The majority of kidney donations can be done laparoscopically nowadays. And the laparoscopic procedure, as compared to a more traditional large incision, what we call an open procedure, means that you will very likely have a shorter recovery time, a faster return to your normal life routine, and less pain. So during that operation, the surgeon will make a couple very small stab incisions in the abdomen and insert a laparoscope, which is a little bit like a cross between a microscope and a telescope that will let them see inside the abdomen with using video cameras through these very small incisions, and then instruments inserted through the abdominal cavity can be used to harvest the kidney and remove the kidney from the body. So you do not typically have the very large incision that it takes to remove a kidney from a more traditional technique. If you're familiar with laparoscopic gallbladder surgery, for example, or obstetric surgery, this is very, very similar. And the majority of cases, over 98% of cases done in the US are done this way, and very rarely will it have to be done in an open manner. The kidney is then taken from the donor operating room and typically walked, right across or down the hall to the recipient, where, it can be put into a fashion where it can be, implanted into the recipient. The patient, the donor and the recipient will then be taken typically to separate areas of the hospital for recovery. Next slide, Chrissy. And that's when you begin the next phase, of your recovery period. For the recipient, there's a steep learning curve in terms of managing your new kidney. And the big thing we ask for the donors is really to respect your recovery period. Typically, you'll be out of the hospital, like Dr. Augustine said, in 2 to 3 days. The first day can be a little rough. No, I'm not going to kid you. There can be a fair amount of pain, but after that first 24 hours, there's really a rapid reduction in the amount of pain and the need for analgesic medications. And typically you're out of the hospital by the end of the second day. Respecting that recovery period, however, means that you might have to alter your usual routine. You might need extra help, especially if you are going to be responsible for taking care of the recipient. And you will have some office visits, and there are some early restrictions in terms of lifting, etc. Next slide, Chrissy. Most people will resume their usual activities within 4 to 6 weeks. And if I had to pick a time frame, the majority of donors will tell me that by 4 weeks, they really feel like themselves again. We will limit your driving for about 2 weeks. And then for women who are of childbearing potential, we ask you to try and avoid pregnancy for at least 1 year. As Dr. Hummel mentioned, there may be some extra considerations for pregnancy after donation, especially if it's your first pregnancy. And we usually ask that you're monitored, by your obstetrician. We ask you to avoid any heavy lifting, and we typically do follow-ups either in person or by phone for the 2 years following donation. Next slide. So afterwards, especially given all of the emotion that is involved around the workup period and then the donation, there has been some, description in the literature about emotional ups and downs. And if you look at some particular studies, people have reported that after donation, they might report some depression, some family conflicts, some anxiety. Some people have experienced some negative concern about negative financial consequences. Overall, 80 to 90% of people say that if they had the opportunity again to donate, they still would. So I think given that, most people report that this is an extremely positive experience, and they feel really good about being able to help somebody else with a life-saving gift. Next slide. So I think of donation as the space where a selfless act, an altruistic act, can really provide the gift of life for a complete stranger, a friend, or a loved one. That's all I have, and I think now I'll turn it back to Chrissy and we can open it up for questions. Thank you, everybody, for attending tonight.
Awesome. Thank you so much, everyone. Okay, so we did receive some pre-submitted questions that we're going to go over, but if anyone has any additional questions, please feel free to submit them in the chat box. So the first one was, how long does a transplanted kidney last? I don't know if Dr. Augustine, did you want to take that question?
Sure, and there is a difference on average when you compare living versus deceased donation. The good news is that early on, the transplant success rates are very good within the first year. 95 to 98% patients are well alive with a functioning kidney transplant. So we do a great job in the early time period. We have worked hard and struggled over the years to improve our long-term survival, and we are seeing some inroads there as well. And now with a living donor transplant, on average, you can expect to see 16 to 20 years survival, which is really great. And with a deceased donor, it depends somewhat more on donor variables, but that number may be more between 10 to 14 years of survival. So that is one of the things we tout in terms of the benefit of living donation is the improved long-term survival. Of course, that can vary from patient to patient quite a bit, depending on their early outcomes, their first-year outcomes, their second-year outcomes. But the high percentage of patients receiving a live donor transplant have good early function. Within the first 1 to 2 days of transplantation, you can see the kidney functioning very well, and they feel a difference. They really notice the improvement in their overall health and well-being within just a day or two.
Awesome, thank you. And then, so what happens if the transplant isn't successful, was a question. Dr. Fatika, would you mind answering that one?
Sure. Something that rarely happens, thankfully, with a live donor kidney. But if it does happen, then the recipient may have to resume dialysis if they were formerly a dialysis patient. And we treat that patient appropriately. There's the possibility we would take out that kidney if it would be in the benefit of the recipient to have it removed. If the kidney doesn't work, then typically we cannot give it to somebody else, nor can we give it back to the donor. But thankfully, it's a very rare circumstance. The recipient, depending on their health, may be eligible to receive another transplant, whether that's from the wait list or another live donor. We've had patients undergo many transplants, subsequent transplants, and I personally have had several patients who through the course of their life have had 5 kidney transplants. So a lot depends upon the particular situation, but the recipient will usually be eligible for another. The donor we care for as we would otherwise, and we try and move forward.
Great, thank you. What are financial costs to living donation? I can answer this one to some extent as a transplant social worker. The living donor evaluation, surgery, and follow-up appointments are all billed under the recipient's insurance. So out-of-pocket expenses for living donors is really travel and lodging. And we do have some discounted lodging rates for donors in the area, some assistance programs. Dr. Hummel did mention some different foundations and organizations that offer resources for donors. The American Transplant Foundation helps cover living expenses. And then the NKR, Dr. Hummel, I know you also mentioned. So yeah, I don't know, anything else on that topic, Dr. Hummel, that you can think of for financial?
Covered it very well. I think the important piece there is that the recipient's insurance pays for the medical costs. And then I think as far as if there's a complication related to the actual transplant episode, then the recipient's insurance would also cover that as well.
Great, great. All right. What if I donate my kidney and I go into kidney failure myself? Dr. Augustine, you want to take that one?
Sure. Well, that's something that we take great precaution to try to prevent. And it's a very stringent process to go through a live donor evaluation. And we turn a lot of people down who want to be donors. As I mentioned earlier, sometimes we uncover health conditions that people weren't aware of, which is good for them, and we can guide them to the appropriate therapy or other physicians to take care of them. There are rare cases of kidney failure, and I've seen in my 20 years of practice, I think I've seen a couple of cases where someone who donated a kidney ended up needing a kidney transplant. One thing that is in place that's an assurance for such patients is that they essentially go to the top of the selection process for a deceased donor kidney if they're listed for transplant. So a previous donor who's listed for transplant will typically get transplanted within days to weeks because they essentially bypass other people who are on the waiting list for each kidney that may come and available. We also, I have followed patients who have conditions such as hypertension after kidney donation. And I think if we're proactive and we monitor them closely, we can prevent any risk of kidney disease by treating hypertension, by trying to advocate for their optimal health. I always tell donor candidates, if you can stay healthy in terms of diet, exercise, physical activity, it's going to serve you very well long term, and that can prevent problems such as hypertension and diabetes after donation.
Thank you. Okay, how often does rejection happen? Are there medications to help? Dr. Hummel, do you want to answer that one?
Sure. So rejection can happen at any point after a kidney transplant. At the beginning, when we give people a kidney transplant, we do something called induction immunosuppression, which is stronger than the immunosuppression patients will stay on in the long term. So we really try to minimize early rejection using these stronger medications early on. I often tell patients that if you have a rejection episode, many times it's not game over because we do monitor recipient labs very closely early on. And then we continue to monitor recipient labs later on throughout their transplant. So there are medications that we can use to treat rejection episodes when we detect them. Often, if we're concerned about a rejection episode, we do what we call a percutaneous transplant kidney biopsy. That will allow us to work with the pathologist to determine if there's evidence of immune cells or an immune process going on in the kidney. And then depending on what kind of that immune process that is, we sort of call it a cellular rejection or an antibody rejection. It's kind of like two flavors of ice cream, vanilla or chocolate. We use a cocktail of medicines to treat appropriately for each kinds of those rejection episodes. And I'll let the others correct me if I'm wrong, but I think the early rejection rates are about 20% or less of patients, maybe like 2 out of every 10 or even less than that, have an early rejection episode defined probably within the first year of getting the kidney transplant. But we do see late rejection episodes too. So we're always, have our eyes and ears open to any change in the blood creatinine level, any change in, the patient's protein level in their urine, anything that may make us, alerted to a potential rejection. And then I would add that in recent years, more technology has become available called cell-free DNA testing. It's a way that we can draw a blood sample from the recipient and try to understand if there's a concern for rejection by testing their cell-free DNA levels. So that's been a new technology that I think has helped us in the field of transplantation.
Awesome. Thank you so much. Okay, so the next question was somewhat already answered. What if I'm not a match for my recipient? Dr. Augustine, I know you did talk about the internal exchange program. Maybe you could talk to us a little bit about, so when someone submits an intake, so the next step is to do the blood tissue type matching. When they're informed then if they're a match or not for the recipient, that's when that conversation happens, correct? Where they're informed?
Yes, and if you go back a few years, if we had a donor candidate who was not a blood type match or didn't match with the recipient, we would typically say, don't bother coming in, don't worry about the evaluation, and we would try to move on to someone else. Now, it is true that it's easier to have a direct donation. It's easier to have a compatible pair, and they can proceed fairly quickly once testing is done and the donor is approved. But if there's an incompatible pair who do not match and there's no other donor that could be tested, then we do encourage them to proceed with evaluation. And we have done a number of internal exchanges. There's also a national program known as the National Kidney Registry. It's actually a private company, but it's served the transplant community very well because incompatible pairs can enter a database through the National Kidney Registry, and they have data on pairs of donor recipient pairs from all over the country, and that can make it that can be an easy way to find a match, especially if a recipient has a lot of antibodies, what we call a sensitized recipient, and they may have antibodies from blood transfusions or women who have been pregnant, or most markedly, if they've had prior failed transplants, they can have a lot of antibodies that make them hard to find a match. So we've used the internal swapping or exchange process, but we've also had some patients go into this National Kidney Registry. So it's just changed our approach. If we have a donor who is incompatible, but they still look like a good donor candidate and they're motivated, we encourage them to continue through the process so that we can look for an exchange.
Great. Okay, if I have a living donor, am I still on the wait list? Dr. Fatiga, do you want to take that one?
Thanks, Chrissy. Yeah, so the way our process works is that everybody will be activated on the deceased donor wait list first, and then we will evaluate any potential living donors. So there's a possibility that you could receive a kidney from a deceased donor while you're waiting for your living donor to be evaluated. The reason we do this is for, UNOS regulations, et cetera, to be able to allocate even the live donor kidney, as well as to make sure that as a recipient, you'll be eligible for transplantation, period. So you will be activated on the deceased donor kidney transplant wait list, even if you have a live donor being evaluated.
Great. All right, last question here. What are some things I can do to get the word about my need for a living donor? The word out about my need for a living donor. Dr. Hummel, do you want to take that one?
Sure, thanks, Chrissy. And I'd invite Rich or Josh to chime in if they know of other ways that people have been successful in doing that. So there's many different ways that people can, let their need be known that they need a kidney transplant and they're looking for a living donor. What I advise patients in clinic often is that it's very uncomfortable and very hard to ask, I think, patients or other people, can you give me one of your kidneys? So I encourage patients just to get their story out there, in conversation with family members, cousins, church group members, card group friends, just to kind of say, like, if they feel comfortable, I went to get my transplant evaluation today because I'm going to be needing a transplant. My kidney doctor is very worried about my kidney function. And then you may be surprised at how many people would step forward and put in, a request to be evaluated. Other folks have done it in very public ways. Many people use Facebook or Twitter or other social media outlets to get their story out and make asks more publicly. Oftentimes we see situations where, parents aren't going to be in need of a kidney transplant and their kids want to donate, and some parents find it hard to take, a kidney from their kid in case they get sick later on in life. So there's many different scenarios. There's people that do billboards and messaging on their car and messaging in pizza boxes. So, there's many different ways, and I guess I would say it depends on your level of comfort as to how public you want to make your story.
Yeah, I think the important thing is, that's a great overview, Ann. I think the important thing is that we can't solicit a kidney for you. So I think the most important thing is making sure that you're not quiet about what you're going through. And I've had patients over the years who haven't even told their kids that they need, a transplant or the rest of their family or loved ones. And it's so important to have that, just the knowledge. And like Dr. Hummel said, even just others knowing about what you're going through can often lead to the interest in donation. I think there's all types of ways, but what you're comfortable with is, usually you'll find your comfort level. If a prospective donor does come forward and is more altruistic, meaning, let's say they saw an advertisement or a church bulletin notice, then we usually do ask that person to go through a couple extra steps in the donor process just to make sure their motivation is sound. But still, those can be really, wonderful kidneys.
What I try to tell, I encounter, as Dr. Fatika mentioned, I encounter kidney disease patients who don't want to ask their family, don't want to burden their family as they see it. And I try to emphasize, and Dr. Hummel touched on this, is the happiness and satisfaction that donors can derive from helping someone they care about. We see this all the time with kids who want to help their parents in terms of donation. And so I really try to emphasize two things to the recipient. One is that they'll only be approved for donation if they're found to be very healthy and it looks very safe for them to be a donor. And number two, the satisfaction they can derive from being a donor, the happiness that they can obtain through donation. It's something that we try not to dismiss. It's a very important part of kidney donation.
Awesome. So great. Thank you so much to everyone who joined and to our experts for sharing all of this knowledge and information. This has been a really good discussion, and we would love to continue it. So please reach out to our transplant team and living donor office. If you are interested in being evaluated as a donor, the best way to start that process is to go online at Cleveland Clinic Living Kidney Donation and click the button Becoming a Living Donor, which will lead you to an intake, which is that very first step. Remember, if you have an intended recipient, it is always best to wait until you hear your recipient is approved and on the transplant list before starting the living donor process. If you believe you may be a potential recipient of a kidney transplant and need more information, definitely reach out to your community nephrologist and ask about referral to a transplant center. Or you are always more than welcome to call our team for further information. This talk was recorded, so if you wanted to rewatch it later or if someone you know missed it, a copy is going to be emailed to you that you can share. Thank you again for joining and have a great evening.